Okay, but then let me continue on with introducing our next keynote speakers. It's Dr. Lisa Howley, and she's the Senior Director of Strategic Initiatives and Partnerships at the Association of American Medical Colleges, that's the AAMC. Dr. Howley is an educational psychologist who has spent 25 years in the field of medical education, supporting learners and faculty, conducting research and developing curricula. She joined the AAMC in 2016 to advance the continuum of medical education, to support experiential learning and curricular transformation across its member institutions and their clinical partners. Before she came to the AAMC, she spent 8 years as the designated institutional official, that's a DIO, that's the abbreviation for that, for the Accreditation Council for Graduate Medical Education, and as Assistant Vice President of Medical Education and Physician Development for Carolina's healthcare system, and that's in North Carolina. This is one of the largest independent academic medical centers in the US, just in case you wonder. In that role, she led a number of medical education initiatives across the professional development continuum, including graduate medical education accreditation, as well as physician leadership development for this large integrated healthcare system. She concurrently also served as associate professor at the University of North Carolina School of Medicine, where she led curriculum and faculty development programs. Dr. Howley also held a faculty appointment in educational research at the University of North Carolina in Charlotte, where she taught social science research methods, led and collaborated on numerous studies of effective education. So from 1996 to 2001, she was a member of the medical education faculty at the University of Virginia School of Medicine, where she designed and led performance-based assessments and simulation-enhanced curricula. So she really did a lot of many different things. And we are really delighted to hear her talk shortly about professionalism and telehealth, painting a picture for optimal teaching and learning. Before we start, though, I also want to let you know that she recently completed a podcast for APHC, and it's available on Apple Podcasts. And it explains some more of her experience and her thoughts on these issues. But now it's time to get started. So thank you very much, Dr. Howley, for joining us. And please take it from here.
Thank you so much. And I really appreciate the opportunity to be here with APHC today at this virtual conference. And the agenda is really impressive. I really enjoyed the earlier keynote with Dr. Wachter. So thank you for, again, this invitation. And it's really fun, actually, to see so many familiar faces, friends, colleagues, constituents joining today. So I really do look forward to this. And actually, what I most look forward to is actually engaging in some dialogue and discussion with all of you. So again, thank you. So I believe you can see my screen. Let me advance. There we go. Does everything look good on your end? Can I get a thumbs up maybe from someone? Maybe Elizabeth? Things looking good?
Yeah,
okay,
looks
perfect.
good.
Thank you. Just like to confirm before I just
of course
get into it. So first of all, my disclosures. I have no financial disclosures, but I do like to share just a couple things. One, I do work, of course, at the association now full-time, the AAMC, and continue to hold an adjunct faculty appointment at UNC School of Medicine. And I come to this work as an educator, an educational psychologist. So I am not a clinician or practitioner or a provider of care. Everything I do is about and really education and how we learn in that developmental process. So I just think it's important that I disclose that and share kind of my lens and my perspective. And a little bit more about the association for those who are not familiar with us. The AAMC, the Association of American Medical Colleges. We are a nonprofit organization based in Washington, D.C., and our members are institutions rather than individuals, although I certainly love working with those individuals who are educators, scientists, students, residents, faculty, the staff that support all of what we do in academic medicine. They work amongst these various institutions that I have listed here on the slides for you. So all LCME accredited medical schools in the US and Canada, their clinical affiliates are teaching hospitals, more than 400 of them, and as well as academic professional societies as well. We recently have been undergoing a new strategic planning process at the association under the leadership of Dr. David Skorton, our fairly new CEO. And as a result of that actually multi-year kind of strategic planning process, we came out with a new mission, although it's just a slight difference from our former mission. But this mission is that we lead and serve academic medicine to improve the health of people everywhere. With the vision, and so we do that with hopes of a healthier future through learning, discovery, healthcare, and community collaborations. I always like to begin with a brief kind of background on what the AAMC is, what we do, and who we serve. So again, thank you for that opportunity to kick us off that way. And I also like to begin by thanking those who are involved in this work that I'm going to be sharing with you. I just happen to be the one here speaking to all of you and sharing this work with you on behalf of a lot of folks. So I want to certainly acknowledge and mention them now. The bottom of the screen first is my core team that I work very closely with at the AAMC, and we are responsible for telehealth education. At least the core team at the AAMC that is responsible for that work is one of our strategic initiatives. Now, all the lovely faces you see on this screen represent constituents, and these are really national experts in telehealth and in education, and of course, telehealth education. These individuals make up our telehealth advisory committee, who have worked since 2018 to help really advance what we do in regards to training and learning in the telehealth space. Their work has really been instrumental in the development of the telehealth competencies, which I'm going to share with you all today. So our agenda is here, and would like to use this time with you to first take a very brief look at the state of practice and when it comes to telehealth, as well as the state of medical education, at least at the undergraduate medical level. So I have just a little bit of data to start here for us. Then I want to spend time talking about competency-based education and specifically telehealth competencies across the continuum. And I titled the session, Painting a Picture for Optimal Teaching and Learning, in part because October is National Arts and Humanities Month, by the way, but also because I want to spend some time describing how these new competencies in telehealth can help you think creatively and a little bit differently about ways to improve telehealth education at your own institutions or within your own educational programs. So, of course, I'm sure as all of you know, local curriculum is local and contextual, depending on your local learning environments, your community environments. And so I want to kind of talk with you and work with you a little bit about thinking about how to integrate education or expand education to incorporate telehealth and telehealth competencies. And then finally, I have some sample telehealth curricula and resources to share with you as well. So I always like to begin with kind of the main points, the takeaways that I hope you leave with today. And that is that telehealth is here to stay, and therefore we need to prepare the workforce to practice in this new environment. The competencies are designed in part to guide these educational efforts from UME to continuing medical education and professional development. And I think most importantly, I hope that you take away that we need your help to design and research really optimal educational practices that support care that is safe, timely, equitable, effective, efficient, ethical, and patient-centered. In addition to kind of starting with takeaways, I also think it's important for us to share kind of common terminology and common terms. Now, when we began our telehealth work, which was several years ago actually now, and telehealth competency specifically, we used this definition. And there's a lot of different terms and terminology, of course, in this space. But I just wanted to clarify the definition we're using in regards to our competency work is the use of technology to deliver healthcare at a distance. And it includes a number of different modalities. And for examples are listed here on the screen for you. Just as there are a lot of definitions for telehealth and virtual care, telemedicine, there's also, of course, lots of ways of thinking about and defining professionalism. This definition or description, if you will, by the ACGME and their common program requirements is one that was very informative and used when we developed our telehealth competencies. So I wanted to share that with you as well. Now, of course, the focus of today's presentation is on medical education, specifically around competency-based education in telehealth. But I would be remiss not to also mention that at the AAMC, we have a number of broader priorities in this space, everything from health equity and working to understand and close the digital divide. Also policy and advocacy work, a lot of legislative issues and regulatory issues in the telehealth space. And then, of course, telehealth's future. So what is the future or near future of this type of practice? And then how can we better support our academic medical centers as they navigate this landscape? So before I share a little bit more with you about telehealth and about some data and our competencies, I want to step back a little bit and ask you to take a look at this picture. And draw your attention. So this oil painting, you're probably very familiar with this. I know this is commonly used and referenced in a number of ways in our field, especially in medical education. But I want to ask you to look at it a little bit differently right now. So this is the Doctor, painted in 1891 by Sir Luke Fildes. It's currently on display in London. And I want you now to consider it, thinking about all the, not just the many differences in how medicine is practiced today as it was 130 years ago, but as we're re-entering kind of the patient's homes, thanks to technology, what are the similarities between this scene and today? In other words, not what's different, because there are a lot of things that are different, but what do you think is similar in regards to how that physician at the bedside of this young child, what is similar? So thank you. Yes, you read my mind. Please, if you would, enter your thought into the chat. I would love to see what you're thinking here in regards to what you think is not changed from 130 years ago. So thank you for someone, Dr. Song says compassion, fear in the patient, concern, concentration, vulnerability, discernment, family involvement, engagement, yes, parents being present, observation and focus, puzzlement, this is great, care, thank you. frustration. Well, thank you for that. We're actually going to come back to this a little bit later in my presentation, but thank you for that. Critical thinking, yes. So thinking and sharing what you feel is enduring, really, right? Thank you for that. So now let me pivot quite a bit, share some data with you about the current state of telehealth. I know you're probably hearing a lot today about kind of practice changes, utilization changes, and this is a data display from the year 2020 that we've collected, and this is practice data. So these are ambulatory visits, as you can see, before March of 2020. The rate, if you will, of virtual care visits was less than 1%, or right around 1%. It increased as much as 50% in May, and then leveled off a little bit to around 20%. And certainly our academic medical centers are recognizing the value and the importance, certainly patients are as well, of this opportunity to continue to provide care in this way. So many AMCs we know are setting future telehealth volume targets around 20 to 30% of their overall ambulatory visits. You know, although the rate of telehealth visits and televisits is not as high as it certainly was in the height, if you will, of the pandemic in 2020, but it is certainly here, and we anticipate it lasting, actually, and only improving. Now I want to pivot a little bit to medical education. Some data for you here. From 2019, 56% of our medical school curricular deans indicated that their curriculum included learning opportunities in telehealth. We were a little prescient, I feel, at the time. We actually surveyed our curriculum deans late 2019, so just a couple months before the pandemic really hit us hard here in our country. And then in late 2020, about a year later, we saw a 63% then of schools reported relevant content in their local curriculum. So we certainly saw an increase there. And we don't yet have data, more recent data, but we will have that shortly, and we anticipate it continuing to showing that it's increasing even further. When we asked those schools about why they were not focusing or had any focus on the topic, and this is back in 2019, just prior to the pandemic, keep in mind, the number one barrier reported was lack of experienced faculty to role model, to demonstrate, and to teach these skills. Well, how do we improve telehealth practice? I actually believe that education is the way. So let me shift now to competency-based medical education, and I want to begin with just kind of a broad overview. I hope this isn't too well known to all of you, but just to give you a quick kind of background on competency-based education and where we've been over the past 20 years. We've certainly improved educational practices in a number of ways, right, in the last 2 decades, including how outcomes such as competencies are defined, how they're used to guide teaching, to guide learning and assessment. CBE has its roots in primary education and psychology, and its use in medical education, as well as other health professional educations, has grown since really the late 1990s, when the Medical School Objectives Project was launched, as well as the ACGME and ABMS 6 core competencies. And, you know, competency-based education, although there's not a single model, there are several common characteristics that I want to quickly go over before I dive in and talk more specifically about telehealth competencies. So I thought it'd be helpful to share these characteristics, comparing traditional with competency-based education. So you can see on the left, I denote this kind of more traditional approach with a lockbox, or a lock, meaning a fixed mindset. And then the column on the right is intended to represent the growth mindset, with a nice little plant there growing. So just to demonstrate the differences here, I won't go through all of these, but I think you can get the idea that our focus has really shifted from process and what we teach and how many hours we spent teaching something or a particular topic, to one of outcomes. So what is it that our learners can actually do as a result of the educational experience, right? So focus on outcomes over process, or even in some cases how we teach. So the additional something else I wanted to point out on this graph, again, without going through all of these rows here, is the nature of feedback, right? And so in a traditional model, the feedback is fairly infrequent, unfortunately, and it's considered rather formal. Whereas in a competency-based model, the feedback is much more frequent to the learner, and it's bidirectional, actually, between learner and educator, teacher, facilitator, or coach. And tracking of performance is almost ongoing, essentially. So very frequent check-ins and tracking of progress over time. Sorry about that. So it is within this framework of competency-based education that we launched a new series, the AAMC, back in 2017. We called this series New and Emerging Areas in Medicine, Competencies Across the Learning Continuum. And the series is intended to guide or serve those who develop curriculum within the field of medicine, or for physicians who are already in training or continuing their professional development. And telehealth competencies were the second in this series. Quality improvement and patient safety were the first. I hope you're familiar with those. And we are currently working on diversity, equity, inclusion competencies as well, and expected to release those later in the year. So before I share a little bit more about the telehealth competencies, I want to ask if you would, for your engagement one more time, consider the continuum of medical or health professions education. Where do you primarily focus? So I realize some of you wear many hats, probably all of you wear many hats, but if you were to pick a primary focus of your work, is it at the UME, the GME, the CME level, or are you really in a position where you oversee all of those parts of the continuum, or maybe none? So if you would just take a moment, all you have to do is enter, as you all have already figured out, yes, one of those options. So see lots of GME, some UME and GME, GME and faculty development, UME. It's interesting. There's a lot. It looks like a good, although certainly not scientific, and I didn't do a poll, but it looks like there's a nice diverse group here, folks, as far as where you work along the continuum. Okay. And feel free to keep entering that. Okay, wonderful. Thank you. So I'm going to share with you a little bit about the scope and approach of the competencies and how we kind of think about our work, at least with this series. We follow this similar approach for all sets of competencies, again, within this specific series. These are new and emerging areas. The competencies are all tiered based on 3 levels for learners across the continuum. So at the level of student or graduating medical student entering into residency, a resident entering into practice, and then a more experienced attending faculty physician specifically. These are all physician level competencies, so they're written at the individual level, not the team or the system level. And they are intended for all physicians, regardless of specialty, which means that they're written at a fairly high level, and that is by design. We would expect and hope, and we know that some already are, specialties would take it upon themselves then to think about how do these competencies apply in my specialty of practice, and then develop more granular either learning objectives or even additional sub-competencies that align to the broader telehealth competencies. They're also informed by existing milestones, EPAs, competencies, and other areas. The process to develop the competencies is rather extensive. In this case, it was 18 months. and involved hundreds of stakeholders, or I refer to them as reactors. I hope some of you are on this call. If you are, thank you, who gave us your input on and feedback on the competencies themselves, multiple drafts, multiple iterations. We took those many comments and feedback points, read every one of them, and used that information to help improve and iterate on another version, another edition, until we ultimately had a final set that was released. We actually released the pre-publication version of the telehealth competencies in late 2019, and then formally released, in late 2020, forgive me, then formally released the report just this March. So in case you're wondering if you've seen two dates, 2020 versus 21, that is why. It also is worth noting, kind of another caveat, is that the competencies may be individual competencies may be considered aspirational, depending on the local or state resources, system structures, policies, and regulations. And finally, one final point I want to make about them is that we are intending to practice a continuous enhancement model, meaning that we're not going to just release these and never put them on the shelf and say we're done. We will be revising, modifying, and updating them periodically, probably on a 2 to 3 year cycle, probably more like 2 years with telehealth. It depends on the nature of the competencies themselves and the topic area that we're focused on. So that is our plan. And because of that, we are requesting that you provide us with your feedback on the competencies as you use them, as you implement them into your practice. So if you would, there's an email address there that we have, telehealth@aamc.org, and we welcome your feedback specifically on those competencies. I keep having issues with my advancing. There we go. All right. So this process and this work ultimately led to the release of 20 competencies in total, organized into 6 domains. The 6 domains are here for you. They're just a very high level name of the domain, everything from patient safety and appropriate use to the specific technology for telehealth and the role of the physician in that technology. I want to share with you, I want to go through and give you some examples of competence. I won't go through all of them, don't worry. But I do want to give you some examples so you get a taste of this. And within each domains, I'm going to give you examples of 4 of the 6 domains. I provide here in the upper left corner of the screen, you see the definition, and that's the domain definition. So in this case, it's patient safety and appropriate use. There are a total of 4 competencies within that domain. And there is one sample competency you see in the middle of the screen that gradually progresses developmentally from left to right, kind of up this ladder. And in this case, this competency is about escalation of care in a virtual environment or virtual space. And so, care escalation is certainly a critical issue in any setting, right? And one's ability to escalate care is certainly complex. It's a diagnostic, a decision-making process. It also involves certainly communication skills, professionalism issues. We've seen some really interesting, actually, we have a nice submissions to Med Ed portal that look at teaching residents and students about how to escalate care and how to navigate some challenges when escalating care. We haven't seen anything yet specific to telehealth and virtual care, but I would love to see some adaptations of that in consideration for is escalation of care in a virtual environment unique, and what are those unique characteristics? For example, what is the role of hierarchy in care escalation in a virtual environment or a virtual encounter? And are there unique issues or challenges in this setting? So for every, this is the first, I'm going to give you 3 more. And for every example, I provide a little kind of, if you will, a little ethical or communication or professionalism challenge, because this audience, I think, is just the right one to help us think about those, and not just think about kind of how you would address that ethical challenge or issue. But I would, go even further and to say, how do we teach that? How do we engage learners in those ethical discussions and conversations and experiences so they themselves can think through and manage these complex challenges in virtual healthcare? So another example falls within the domain of access and equity in telehealth. And here you see one of 3 competencies within the domain. In this case, it's what is the impact of the digital divide on the care of a patient, and how can the physician mitigate that inequity? So the kind of ethical challenge here that I pose for all of you is, what is the role of the doctor in decreasing the digital divide for her patients? What if audio-only chats become a billable telehealth service when not in the past? And so if you listen to the recent podcast by APHC, you will have heard Dr. Preston Reynolds from UVA pose that ethical challenge to me. And I said to her at that time, I said, that's a great question for APHC and the experts that you have here who really are quite expert and experienced in thinking through these ethical dilemmas and regulatory issues. So I bring that back forth to you today and invite you to think about that, consider it. And again, how might you engage learners into that discussion as well, and think of it as a learning opportunity. So the third example falls within the domain of ethical practices and legal requirements for telehealth. And there are 4 competencies within this domain. The competencies here address local legal and privacy issues, informed consent, issues of conflicts of interests. There is lots of new commercial industry coming into this space and telehealth, so how do physicians navigate that? Broad ethical and professionalism challenges, including the one that's here for you on the screen. And so again, I invite you to help us think about how might faculty engage learners in these ethical discussions about telehealth. So the fourth and final example that I'll give you falls within the domain of communication via telehealth. There are 3 competencies within this domain that address rapport building, privacy issues, family or caregiver interactions. And I want to draw you back to that painting that we looked at earlier, The Doctor by Luke Fields. And just so ask that, how will doctors continue to establish trust with patients if they cannot meet them face to face? Which is the challenge, a professionalism challenge I have here for you for this slide in this domain. According to Nick Morgan, a communications expert who recently published a book, it's called Can You Hear Me? How to Connect with People in a Virtual World by Harvard Business Review Press. He says that every form of virtual communication strips out the emotional subtext of our communications to a greater or lesser extent. And I think that's, it's really interesting time for us to think about what are the implications of this virtual connections and connecting with patients in this way for the doctor-patient relationship and doctor and team relationship and doctor and the doctor's physician's well-being and how they practice self-care when they may be asked to work as they are now in a hybrid way, if you will. Some patient visits are virtual, some are face-to-face, as just one example. So now that I've introduced the competencies and posed several of these challenging questions for you, at least I think they're challenging. Maybe you all disagree, but let's discuss how you might use these competencies, again, to kind of paint your own picture of optimal teaching and learning in your own educational programs. And so I've laid out here just 6 examples for how we think about so what are the use cases or the intended uses, if you will, of these competencies, engaging with health professionals and improvement or education discussions, including those that work across the continuum. Many of you, I know that you do work across the continuum. It's actually wonderful that we do have such diversity in this group in that regard. And so connect with those that you work with. If you work in the medical school space, what are the residency programs doing in regards to teaching and learning telehealth? What are your faculty development CME programs offering? So working across that continuum, and of course, even across professions within medicine, across health professions, how is nursing tackling this? They're doing some interesting things, actually. So thinking about reaching out and working with your colleagues and educators across professions, across your own institution even. You can also use these competencies to identify gaps in your own practice if you are a clinician, and plan for your own improvement or continuing medical education. And finally, I'm not going to get the last one here. You see on the right side is conduct research and scholarship in CBME as it relates to telehealth. We certainly have a lot to learn about the optimal approaches to teaching and learning telehealth. And as I've already laid out kind of in regards to professionalism, communication, and ethics, and I would encourage all of you as experts in this space to help us advance the scholarship here, and share and develop new resources, educational scholarship that we can share across our community. And for those, let me get a little more granular, those who design educational curricula, I also want to share some this model, which you're very familiar with. I'm sure this is David Kern's model of curriculum design, probably the most widely used model in medical education. And so my little yellow arrow here on the right side of the screen, I placed here just to prompt you and to have you think about the telehealth competencies as an opportunity to help you identify what the needs are. So in other words, identify a problem or gap, and one or more of the competencies can then inform the rest of your curricular design. So think of the competencies themselves as the needs in your needs assessment. And again, depending on where you work in the continuum, and it looks like we have quite a spectrum here, a diversity of folks who work across different parts of the curriculum. This graphic I put together, and if you work, for example, here we go. So if you work in the undergraduate level primarily, I ask you that you consider the first tier, which are the expected competencies for a graduating medical student in telehealth. So what existing learning objectives already address those competencies across your entire educational program? Where are there existing opportunities to teach and or assess these competencies? And whether, in various synchronous, large synchronous, small groups, simulations, clerkships, electives, standardized patients, nearly all of our medical schools incorporate SPs into their educational program, as I'm sure you know, and thinking about incorporating telehealth visits into those SP encounters is actually a wonderful way to teach and or assess telehealth competencies. So think about what's already happening, what's already going on, and then where can the instruction around telehealth and assessment of these competencies fit in. So if you're at the GME level primarily, I think you have similar questions, but I phrased them a little bit differently for you. So what existing learning experiences already address those competencies, such as milestones? I know the internal medicine, patient care 6, digital health milestones are certainly relevant here. So if you're already doing work in that space, how do they align to these competencies? And where are there, again, existing opportunities in your GME programs or even in your specialty societies for your learners to participate in? And here we go. So if you work primarily at the faculty development, CME or CPD space, again, do existing local training opportunities already align? And then if not, what external training programs exist? So there are a growing number of CME programs here for teaching of practicing clinicians or upskilling them. It's interesting that they see more and more of the term upskill for practicing clinicians and physicians to improve or upskill themselves in regards to telehealth. So a growing number of those are available externally. I still would encourage the use of SPs, the use of simulation across the entire curriculum for these skills, which are, again, quite new to the vast majority of our learners. And as I'm going to close by sharing with you several examples and different curricula, just so you can get a taste for what's being done. A lot of innovation in this space, which is wonderful to see. But before I do, I have just one slide here. And this, if we were together and this were a workshop, we would be diving in and working on this together and using this as a worksheet. So this is kind of a way to step back and think about the principles of adult learning that were put forth nearly 50 years ago by Malcolm Knowles. And he's the author of The Adult Learner. And again, you're probably very familiar with this. I put a little bit of spin on it. So the principle on the left side is consistent with Knowles' 5 principles for adult learning. I provide a little bit of detail for you here. I add my own little quote here. So experiential is learning by doing. Remember that the best learning activities and learning experiences ask your learners to do, not just sit and think or reflect. And so as you look at this and read through these principles and details, think about how you could apply that locally. So given your own local educational experiences for telehealth, are they kind of meeting these 5 principles? Now, there's certainly other things and considerations to keep in mind, but I think this is at least kind of nice to consider these fundamentals of adult learning principles. Okay. So as I said, just wanted to finish up here or begin to wrap up by sharing with you several examples of some wonderful innovations in this space. And I also want to say, I know that there's a lot more that we aren't aware of. So I love hearing from you. I love hearing from our constituents, the educators, about what you're doing, what you're creating, what you're pilot testing, what you're thinking about, what you're researching. So please reach out and let us know what you're doing in this space in regards to telehealth education. Last year, we invited these 3 institutions to share their telehealth practices. We knew that they were doing and had been doing quite a bit of work in this space. So we reached out to them and asked them to put together some videos for us. So there are each video is about 4 to 5 minutes in length. If you haven't seen these, I would encourage you to take a look. And I'm happy to share these links with you later. But take a look and just think about what are the lessons, that they are learning and the innovations that they're putting into place that may be informative to your own work and your own practice. Just to give you an idea here, Stony Brook Medicine, to give you a sense of what some of the work that they're doing. They have a pretty robust curriculum there around telehealth. They have a course called Docs, Data, and Disruptive Technologies. They also have a very strong interprofessional program that teaches telehealth, again, across multiple professions. Jefferson has integrated telehealth content throughout their curriculum. It's aligned with our AAMC telehealth competencies. And UC Davis has also a really long history of telehealth and robust curriculum that spans the full continuum from UME to CME and faculty development. We have other examples on our website that give you, pretty, not lengthy, but enough description, I think, to at least tease you. And if you want to connect with any of these educators, I'd be happy to help make that connection. We have UAMS, Texas Tech, and Emory are other examples of telehealth curriculum that we're happy to help connect you with and share. And speaking of models, this year we awarded 5 Tech Awards, which stands for Telehealth Equity Catalyst Awards. And we awarded those to these 5 institutions listed here. They were awarded because they really demonstrated positive impact on barriers associated with telehealth and health technology. So they were really focused on health equity and access. The first and the last, so Connecticut Children's and Wayne State, I kind of called those 2 out because their work is specifically focused on education And just given the nature of our talk today, I thought I would point that out. But all of these examples all these institutions have nice examples of telehealth in practice. And again, Connecticut and Wayne State are specifically focused on residency education and then interprofessional undergraduate medical education as well, with interprofessionals. We currently have a call out, if you're not familiar, by MedEd portal on telehealth education, as well as anti-racism and integrated behavioral health. So I call that to your attention. We really would like, as I said, your educational scholarship in this space. So please connect with us, consider submitting to MedEd portal your telehealth education scholarship. If you don't know what MedEd portal is, please reach out. I would love to talk to you about MedEd portal. It's one of our 2 journals, and it is now peer-reviewed and indexed and has thousands of educational scholarship and resources. Includes not just the description of the curriculum, as you might see in a more of a common journal. This journal is quite unique in that the tools are readily available for you, meaning the educational tools to support that curriculum are available to you free to download, adapt, and use for your own local practice. So it's a wonderful resource. And again, if you are not familiar, I'd be happy to talk to you more about that. So in addition to MedEd portal, Academic Medicine, our 2nd journal, we would also love your submissions to AAM, Academic Medicine. And there are this certainly is not exhaustive. I just wanted to give you a few examples from both journals, actually, that address telehealth education. So this slide just includes a few examples, a few references from each of those 2 journals. So finally, I want to briefly mention a second report, which is here on the left side of the screen. This was released in July. It's called Sustaining Telehealth Success. It includes mention, of course, of these new telehealth competencies, but it also speaks to the much broader issues and challenges that our health systems are facing in adoption, integration of telehealth clinical services. So just encourage you to take a look at that report. And then just released today, like hours ago, hot off the presses, is the report on the right. And that was released and done in partnership with the AMA, actually, and it's a guide. It's really intended to stimulate critical thinking about language, narrative, and concepts in our collective efforts to advance health equity. Of course, health equity is one of our telehealth domains, competency domains, and we have integrated actually throughout all of our competency in this series. So this language guide is not specific to telehealth, but it is specific to health equity, and I thought it was quite relevant and pertinent today. And I know that all of you educators here joining us today would find that also very interesting, and I hope helpful to your own practice. So just in closing, I want to revisit these takeaways and thank you again for the opportunity to join you today. So telehealth is here to stay, and we do need to better prepare our workforce to practice in this new way, in these new environments, to support them in their own well-being as they navigate this challenge in these different ways and different innovations. The competencies are just one piece, one tool to help support and guide these educational efforts. And importantly, and lastly, we do need your help to better understand how we can design and research optimal educational practices in telehealth that support healthcare that meets the aims of safe, timely, equitable, effective, efficient, ethical, and patient-centered. So again, it's my pleasure, and I look forward to having some time a little bit of time here to have a discussion with all of you. If we run out of time and you have more questions or just want to connect with me on telehealth competencies or anything else at the AAMC, please do so. Here's my contact information. My email is on the bottom left corner of the slide. And all these resources I mentioned can be found on our website. But if you have any problem finding any of them, just reach out and let me know. Thank you so much.
Well, thank you so much for this very interesting and full of resources presentation. We have an international audience here as well, and I please reassure to them that they are also able to access them and to contribute to them.
Yes, absolutely. That is very true. Thank you. Yes, these resources are not for members only. They are, AAMC members. They are, yes, freely, readily available. Yes, thank you. Thank you for pointing that out.
Great. Thank you. So we have 10 more minutes. If you have any questions or comments, this is a good time to ask them. Who would like to ask a question? Maybe there's something in the chat. Other than that, it's an outstanding presentation. It's certainly yours. Yes,
I'm
please.
getting caught up. Thank you, Barbara. Elizabeth, I'm getting caught up. I haven't been able to watch the chat, of course, while I've been talking, but I love all these examples of using SPs to train via telehealth in different ways. So thank you all for that. Those are fantastic. And reach out and let us know more about what you're doing. I really do mean that. Yes, we want to learn with and from all of you, and importantly, connect you with those who are really seeking help, educators who might be struggling in one particular aspect or way of teaching and learning, such as telehealth. To connect our colleagues or constituents together to learn from and with each other. So please do reach out and let me know what you're up to. I'd love to hear more about it.
Mm-hmm. I think Serene has a question or a comment. No, she just turned on her video, which is very kind. It's always nice to see some faces. There is a question in the comments in the chat, though, about assessment in virtual environments and the whole issue about how to assess these competencies. Do you have any more thoughts on that, please?
Sure. Yeah, well, assessment is a challenge no matter what the environment is, right? But it really depends on the competency and what we're talking about assessing. And now, of course, the competencies themselves are not intended to be directly assessed. I mean, we can't take the competencies and then turn them into a workplace-based assessment tool. That's not their intention. But there are assessment tools such as communication skills, professionalism. I'm sure you all actually are quite familiar with the myriad of assessment tools that already exist. The question is, how can we adapt those to interactions that happen to be taking place in a virtual space? And to be honest, I am not familiar yet with any quite yet of tools that have been specifically designed for assessing skills, communication skills, for example, that take place in a virtual environment, in virtual way. So it really is quite a ripe space for innovation, for scholarship and research. So,
and definitely OSCEs, that's one of my favorite topics. So OSCEs and standardized patients, I think, can really contribute a whole lot to it.
Yes, virtual visit OSCEs, we are seeing that, which is, I should have mentioned, actually, it's a very interesting, innovative. So we are starting to see some of that taking place. And it's, done quite honestly through Zoom with standardized patients. There may be some others. I know there's some SP educators in the audience who probably have experience there. We highlighted some of them actually at one of our learning series webinars in the past, back in 2020. So if you have specific questions or you want to be connected with some educators who are offering and conducting virtual OSCEs, let me know. I can make that connection for you.
Great. Tom Harder, he has his hands up.
Thank you, Lisa. Really great presentation. Thank you for being here with us today. Given your background in educational psychology and this presentation on telehealth, I'm curious, what do you see as potential barriers to some of these initiatives, right? And things that really need to be overcome to make virtual learning successful in a variety of environments, because there's the transition to virtual care and virtual learning certainly favors those in more urbanized areas versus rural areas. So I'm wondering, do you see geographical differences as a potential barrier, or are there things that we're just not thinking about that are hindering some of this?
Yeah, so Tom, thank you. Where are you? Where are you from?
La Crosse, Wisconsin.
Ah,
yeah.
Excellent. So yeah, I mean, no, as far as, so there are many barriers, right? And, interestingly, some of the barriers that we thought, at least from the practice side, would take many, many, many years for us to address or resolve or even think about, because we thought they were such big barriers, regulation issues, billing issues, issues of licensing, right? So there are these really big challenges. And not that I would thank COVID for anything, but I have to say the COVID pandemic has created an environment where we were forced to overcome these challenges and barriers when it comes to practicing telehealth, right? And I think similarly, we've seen barriers overcome in the education space as well. 2 years ago, I think thinking about the ability to offer in a meaningful and effective way a virtual OSCE and have that adopted widely and broadly for, as it is now in some schools, I don't think we would have imagined that. Or even, I can tell you, I've been working in telehealth education for many years, actually, and I did this prior to coming to the AAMC, and the resistance and that I had to it, I had, everyone saying, well, why do we need, I have too many other things that are more timely and more kind of the here and now. Why do I need to worry about that? Or the other barrier I would get quite often is that these aren't skills I need to learn. I'm already a good doctor. Therefore, that translates to being a good doctor in a virtual environment, a virtual space. So I'm saying that I think, we've already overcome a number of barriers that just a couple of years ago we thought were really formidable. Like, how could we possibly tackle those barriers? So I think whatever we think is a barrier today, I hope that we kind of lower the bar in thinking about how difficult it might be to overcome them, because I'm really optimistic and have been pleased with how much progress, that forward movement we have made in this space, in telehealth space. So kind of a more of an optimistic, half as glass full way, I guess, of answering your question. Not to say we don't have barriers, and yes, Wi-Fi and access is a big one, actually, not just for patient care, but also for learning and those resources that it takes we certainly have inequities in that. And we're certainly hoping to support our academic medical scanners in overcoming some of those. And yes, thank you for the challenging question.
Yeah, our leadership doesn't call them barriers, we call them opportunities.
That's a nice way of thinking about it. We have a few more minutes left, and are there any other comments? I see several people turned down their video. I don't know whether that means that you would like to share something or ask something. Yes, Jean.
How are you, Elizabeth? I was just waving hello.
Just
I
hello.
always like to see people too, so
yeah,
I just had to
Thank
get
you.
off the phone.
Thank you, Jean.
Well, I just want to say that we know that assessment drives the curriculum, and I think once telehealth competencies are being assessed one way or another in heavy set assessment programs like licensing boards and things like that, I think that will make a big difference. But maybe we aren't quite there yet, but I hope we will get there. Somebody else wants to say something? Erica, did you want to ask a last question? Oh, David Dukas, please. I think you're mute for some reason. We can't hear you. Yes? Still, maybe it's a transmission problem. Yeah, sorry. Maybe put it into the chat and Lisa can respond to it. And Preston asked, is there any data about how much health systems are invested in telehealth education? That's a good one. You would like to answer that as the last question?
Sure, I can tell you at the moment, we do not have that data. We are, though, actively collecting and reaching out and data on telehealth in this space quite frequently, actually, to everywhere, including CEOs and CFOs. So I don't have any data for you on that now in regards specifically to the education space, but it's certainly an area that we're working in, and it won't surprise me if we do have data in that area coming up.
Right, and that might be a source for some more financial support for these types of programs. Mm-hmm. So David, please put it into the chat, your question, and Lisa, please respond if you can. There's also the possibility for anybody who wants to, if you're available, to go into one of the network rooms and to continue the discussion during the break. We have a break coming up now for 15 minutes, and it will be a chance to just continue either here using the chat or going into a breakout room. I think David just asked the question. But we have to stick to the agenda. So let's move into the break now, but please continue the chat. It will continue on in the main room.
And thank you again. David, I'll answer your question in the chat.
Yes.
Thank you so much, and enjoy the rest of your day, everyone.
The thanks go to you, because we are really appreciative of all that you've shared. It was really a very interesting and productive presentation. So I think it will bring many people to new ideas. It will give many people new ideas, and it really helps a great deal to move this forward. Thanks so much.